Good morning and welcome to our February educational call of the Ohio Hospital Association's statewide sepsis initiative. I am James Giuliano of the Ohio Hospital Association, and as is our practice each month, we always begin our calls by revisiting the goal of our statewide initiative, that being to achieve the OHA's board-directed goal of a 30% reduction in sepsis mortality statewide by the fourth quarter of 2018. Today's program is the first in a series intended to consider the continuum of care. Before we begin today's session, we would like to address just a few important details. First of all, a vital component of our statewide initiative involves the collection of data. Let me take a moment to remind our participating hospitals to please submit your monthly numerator and denominator data regarding compliance to the elements of the 3-hour bundle. Secondly, please know that you will be given an opportunity to type in questions through the chat box feature throughout the presentation. Questions will be addressed at the end of the presentation. Third, just to let you know, this presentation is being recorded and will be posted on our sepsis webpage, which can be visited at ohiohospitals.org/sepsis and clicking on the education link. There you will find all the previously recorded sessions that do not contain data. Lastly, to let you know, this program has been approved for 1.0 contact hours of continuing nursing education. If you wish to claim this activity, please be sure to complete the sign-in sheet and the evaluation form and to fax them back to OHA using the fax number that's listed on the top of the form. It is imperative, though, that you provide the correct email or postal mailing address to which you wish to have your certificate sent. So please be sure to do that. Our topic for today's call is pre-hospital considerations in sepsis care. Knowing that greater than 80% of sepsis cases are present upon admission, we are intentionally focusing upon pre-hospital care first. The challenges and the realities of early recognition and early appropriate intervention in the field by EMS providers is one that we as acute care providers must consider. Timely, consistent care begins with collaboration with our EMS colleagues. Saving lives through timely sepsis care requires a true partnership. Joining us today as our presenter is Dr. Paul Zeeb, an emergency medicine physician at Mount Carmel Health System in Columbus, Ohio. Dr. Zeeb is also the chair of the Region 4 Physician Advisory Board of EMS. He has been instrumental in developing an evidence-based EMS sepsis protocol. At this time, it is my pleasure to welcome Dr. Zeeb. Dr. Zeeb, you now have the floor.
Thank you, Jim. It's my understanding we've got about 35 minutes of discussion, then we'll open up for questions. Is that correct?
That is correct. Thank you.
So as Jim mentioned, I'm a practicing emergency physician. I've been involved in emergency medicine or pre-hospital care for a little over 30 years. I am an active clinician. I currently also serve as a medical director for a consortium of 18 EMS agencies in the eastern Columbus metro area, extending out into Licking and Fairfield County. And we have been talking regionally regarding sepsis and its effect on our patients and effect on our practice. You know, I have this titled Sepsis EMS's fourth time critical event, and I think we should all consider that. You know, for EMS, the first time critical event was trauma followed by STEMI and then stroke, and now sepsis is on the horizon, or actually is here as our fourth time critical event. Before I get into some of the details about sepsis, after talking with Jim, I've made an assumption that most of our listeners are not intimately involved with EMS. So I'd like to just have a couple slides to talk about EMS as its current state in Ohio. So I can have the next slide, please. So there's a saying out there in EMS that if you've seen one EMS system, you've seen one EMS system. Each system is unique. Each system has its own capabilities and limitations. Each system has its own level of training. Next slide, please. So if you look in Ohio, we have in Ohio at least 1,100 EMS systems as registered with the state. And again, each system is different. Some of those systems are paid full-time firefighters or paramedics. Other areas have limited finances and a fairly small run volume, and they have part-timers who are paid to staff the ambulance to provide care. And then there are other areas, particularly in the more rural counties, where EMS is entirely a volunteer service. So with these different staffing models comes inherent limitations and training issues that have to be addressed. In addition, in Ohio, we have fire service based EMS. We have EMS that is public service but called third service. In other words, it's not part of police, it's not part of fire, it's a standalone EMS service. And then we also have private service entities that provide pre-hospital care in certain areas of the state, and those may be either a nonprofit entity, or it could be a for-profit entity that's under contract to provide a certain level of service in a geographical area. We also have issues related to level of training of the providers. Currently, Ohio follows the federal NHTSA standards in terms of training and certification of pre-hospital providers. The most basic level is called emergency medical responder. I don't even have them listed on the slide. They're generally providers who can provide general first aid until somebody else arrives on scene. They generally do not transport patients by themselves. So for us, really the most basic level is the EMT. They have completed a course of training and have been certified by the state. We also then have EMT advanced, and they are able to do more things such as start IVs and IV fluids. And then paramedics, who are the providers who can provide full advanced life support services, as well as provide other interventions and do some limited testing. All of our EMS providers are required by law to be authorized by a medical director to practice within their scope, and medical directors typically have different protocols under based upon the fire department. There are some areas, such as the Dayton area, that has a regional protocol, but many other areas in the state have a local protocol that's determined by their medical director. We also have EMS regional physician advisory boards in the state. They are responsible for reviewing care in their area, making recommendations to the state regarding opportunities for improvement or other administrative or regulatory changes that should be considered. They're also empowered to make some changes to the state trauma triage criteria. In other words, make them a little more stringent than published by the state. But the physician advisory boards have not really been involved in sepsis yet, except for within the past year. Next slide, please. So if you look at our state scope of practice, I've kind of thrown out some important items that we need to consider as part of our pre-hospital care of septic patients. All of our pre-hospital providers can provide pulse or obtain pulse oximetry and end-tidal CO2 readings, regardless of their level of certification. And in Ohio, end-tidal CO2 is going to be required by the 1st of 2021 for any agency that's providing airway adjuncts such as intubation. Advanced EMTs and paramedics can intubate patients. Only advanced and paramedics can provide IV fluids. Paramedics only can use vasopressors. All of our providers can do finger stick blood sugar at the scene, and advanced EMTs and paramedics can perform phlebotomy. I'm going to discuss toward the end of the program IV antibiotics, and if we ever consider that paramedics are the only providers who could do that in the field. So I put the scope of practice up there because when we talk about pre-hospital evaluation and treatment of septic patients, we have to often think about things that can be done by all levels of providers, rather than restrict evaluations and interventions just to those that can be done by an EMT or a paramedic. A lot of pre-hospital care is provided by an EMT, and they are the only providers available on the field. Next slide, please. So in terms of EMS authorization to practice, as I mentioned earlier, EMTs can only practice as authorized by their medical director. The medical director cannot authorize any clinical practice that's outside of the scope of practice as defined by the Emergency Medical Fire and Transportation Services Board. That is the board that oversees EMS and pre-hospital care in Ohio. And providers are authorized to practice either via written protocol approved by their medical director or by direct instructions with online medical control. But in most of Ohio, online medical control is not something consistently provided for EMS providers. In other words, EMS providers rarely call into a hospital emergency department to solicit input and direction from a physician. Next slide. So for us, sepsis, whether we're talking about the septic patient in the emergency department or the septic patient in the field, it's not that simple. ED providers and EMS providers can evaluate a chest pain patient, obtain a 12-lead ECG, and if it's positive for ST elevation MI, they can activate the STEMI alert system and get the patient to the cath lab. So STEMI patients are fairly easy to identify in the field for our paramedics. Trauma is one of the other earlier time-critical event, and trauma criteria in terms of transfer criteria to a trauma facility is defined by the state. It's legislated. If the patient meets criteria, they must go to a trauma facility unless there's an issue regarding need for stabilization or patient request, or going to a trauma facility puts an unnecessary strain on the EMS system. But generally, patient criteria for evaluation at trauma facility is legislated. It's pretty straightforward. For stroke care, stroke patients typically have some defined onset. There are various screening exams that we can use to screen for stroke and make transportation decisions. We're still working out which it may be the best screening criteria, but stroke generally for EMS is a pretty straightforward finding. For us, so sepsis is a difficult finding. It's not always a patient with a fever with abnormal vital signs and elevated serum lactate. So for many of us, it may take time to determine whether or not the patient's septic. And that is as true for the patients in the field as it is for the providers at the hospital. Next slide, please. So for us, another thing to consider is mortality rates. I think everybody's aware that sepsis is a very deadly condition. It has a much higher in-hospital mortality than STEMI or trauma. Typically, if a patient survives to arrival at a trauma facility or a STEMI facility, they have less than 5% chance of dying, whereas current state risk of death runs between 28 and 50%, and these are CDC numbers, and it all depends on how you're looking at the definition of sepsis, whether it's septic shock versus all sepsis patients. So for those conditions that we treat, sepsis is truly the most deadly for our patients. Next slide, please. We also have to think about the mindset. So in the emergency department, in the past, we've talked about sepsis, severe sepsis, and septic shock, the new criteria, either the patient's septic or in septic shock. But we can also take time to sort it out. We may institute therapy initially based on a presumption of sepsis, but eventually things start to fall in line. For the EMS providers, they have typically been taught to look at a patient from a perspective of sick or not sick. And there's not a lot of stay and play where they'll stay on scene trying to determine what is wrong with the patient and what's the best treatment plan and where should they go. So there's a bit of a different mindset for our providers. I think our EMS providers also are well trained, but they're not physicians, they're not nurse practitioners, and their ability to make a determination of sepsis versus non-sepsis can be more difficult. Next slide, please. So let's talk a little bit about pre-hospital screening. If we use a STEMI or a EKG to evaluate for possible STEMI, if we use a stroke screen as a possible way to evaluate for stroke, is there something comparable that we can use in the pre-hospital setting to screen for sepsis? So, is there a suitable pre-hospital screen? And also, if we're going to talk about screening tools, what is a suitable level of sensitivity, specificity, positive predictive value, or negative predictive value? In other words, how do we readily identify a potentially septic patient in the field, and what screening tool do we use, and what is our false positive rate going to be, our false negative rate? What is an acceptable level of over triage for sepsis patients? Next slide, please. So, what is the what are the determinants of a reasonable pre-hospital screening tool? I think the first thing we have to think about is the tool suitable or not for all levels of training and knowledge for those providers in the field. So we have to think about the provider with the lowest level of training, which would be the EMT. If we develop criteria that are only suitable for a paramedic, a significant number of our patients in the field will not get appropriate pre-hospital screening for sepsis. The criteria must be also measurable in the field. If you look at the past sepsis criteria, or if you look at the SOFA criteria, or even if you look at some of the proposed tools to be used for pre-hospital providers, some of the criteria that are evaluated and measured are just not possible. An easy example was serum lactate. The EMS providers currently don't have a good tool or a good device to use in the field to directly measure lactate. So if lactate is one of those screening tools we're going to use to determine sepsis or potential sepsis, providers in the field have to have a good way to do it, and currently that technology doesn't exist. There is some portable technology available, but it tends to be moderate complexity laboratory test, and it requires an $8,000 device with a $20 cartridge. To expect our EMS providers to have one of those on every truck, I think is financially just not possible. Whatever we do has to be within their scope of practice. So if we're going to require that certain things be done, all of our providers should be able to do it without violating scope. There must be suitable sensitivity and positive predictive value, and I'm not sure that has really been determined in terms of thresholds. What we would like to do is to identify, most, if not hopefully all, of our septic or potentially septic patients, but we want to also avoid sepsis alert fatigue, where medics call in and ask for sepsis alert, and there's not a robust response because we find that the sepsis screening tool over triages patients as sepsis alerts. So we have to have some discussion about that. And then that tool that we use needs to be linked with actions that we expect our providers to do in the field. And those interventions should be continued, or be interventions that we should expect to continue on a patient arrival in the emergency department. So if we expect our providers to identify a potentially septic patient in the field, we would want them to start treatment, which for most of us would be aggressive resuscitation with IV fluids. Once the patient arrives at the hospital, there's a suitable reception by the staff at the hospital. The bed has got enough providers to care for the patients. Interventions by the paramedics or EMTs is continued, such as the fluid bolus is continued and completed, supplemental oxygen, respiratory support, whatever. But it all has to be linked so that it's that continuum of care that Jim alluded to as part of his introductory comments. Next slide, please. So there's been discussion about SOFA and QSOFA. SOFA is the new criteria suggested that we use in the hospital, particularly in the unit and on the floor, to screen for potentially septic patients. This has been abbreviated to the quick SOFA or QSOFA, and has been put out as potential tool for our medics to use in the field. There's the QSOFA has to do with hypotension with a pressure less than 100 systolic, altered mental status, and tachypnea with respiratory rate over 22. If the patient has two or more of those criteria being positive, then there's this correlates with sepsis, and we would expect to link that patient to aggressive treatment for sepsis with IV fluids and so on. This was studied in the field and recently published online through the journal Pre-Hospital Emergency Care. It was found to have a 16.3% sensitivity with a 97% specificity for patients confirmed with severe sepsis and septic shock. I think the specificity is great. So that we would think that if the patient has these criteria, then it's very little over triage. But a sensitivity of 16% means we're going to miss, 84% of patients who are potentially septic with this screening tool. So from a sensitivity perspective, not a great tool. Next slide. There's also a recent Cochrane review of sepsis screening tools published in the Bureau of British Medical Journal, I'm sorry, looking at identification of patients with sepsis in the pre-hospital environment, and they looked at all the different screening scores or screening tools that have been proposed, and they are all of variable sensitivities and specificities, and there are many here. There are some other tools out there that have been proposed. For instance, from Dr. Travers' list at the bottom of the page, one of the screening tools is what they use in Nova Scotia, where Dr. Travers is. It's a very elaborate tool, but in Nova Scotia, they have a lot of pre-hospital care provided in many clinics staffed by paramedics, where they have the time to go through a further rigorous screening process before transferring the patient for sepsis care. Next slide, please. So the study or the opinion expressed by the British Medical Journal was that there are some very broad search criteria. There's little evidence regarding pre-hospital sepsis screening. The studies were of disparate methodologies. There was generally a small number of patients, and the studies that were published advocating on behalf of the various sepsis screens were really of low quality from a research perspective, and that the conclusions drawn regarding these tools really are limited, and really we should interpret any of the results of these studies with caution. Next slide, please. So what have we done in Central Ohio, in a large part through the efforts of Dr. Kessig, who's the medical director at the Columbus Fire Department? We've looked at this article as a basis to develop a sepsis tool for use in Central Ohio. It's been endorsed by our regional physician advisory board, and many of our EMS agencies have started to adopt what's suggested in this article. And I know Columbus Fire has adopted it. My agencies have adopted it. Most of us adopted it the first of the year, so it's too early to say whether or not it's providing value. But basically, this study looked at using some abbreviated search criteria coupled with end-tidal CO2. All of our providers can measure end-tidal CO2 in the field as long as they have the equipment, and end-tidal CO2 has been shown to highly correlate with elevated lactate. So if a normal end-tidal CO2 is 40, an end-tidal CO2 of 25 or less highly correlates with a serum lactate of 4. So if you look at the screening tool outlined by this article, they looked at patients with a temperature greater than 100.4 or less than 96.8, or a respiratory rate of greater than 20, or a heart rate greater than 90. So they use those as vital signs as part of a SIRS tool. If the patient had 2 or more of those criteria and had an end-tidal CO2 of less than 26, meaning 25 or less, then this correlated highly with severe sepsis and septic shock, and could be used to predict the patient might be septic. It has sensitivity rate of about 90%, specificity rate of 58%, not great, but okay, and a negative predictive value of about 93%. So we felt that all in all, this was a reasonable screening tool when you look at its predictive value coupled with the capability of the EMS providers in the field and the resource they have available in the field or in their ambulance. Next slide, please. So what can we do in the field to improve sepsis care? I think we can look at several key measures. So for us, a lot starts with the assessment. Have that high level of suspicion. What are the high risk features? Is there a suspicion of infection? If you look at some of the screening tools I alluded to earlier, several of them use patient's age or residence in a nursing facility as a risk factor. Look at the patient's vital signs. Again, looking at those SIRS criteria. A brief focused exam. Is there identified source of infection, such as symptoms of pneumonia, symptoms of a wound infection, symptoms of decubitus? Perform capnography in the field. It's very easy to do. You put a nasal cannula on with a special sensor. You hook up to the monitor, and it'll give you a value of end-tidal CO2. If appropriate, check a finger stick blood sugar. Septic patients could also be hypoglycemic. Plus, if the patient's diabetic, that increases the likelihood of severe infection. And in some circumstance, maybe at some point, perform a serum lactate in the field. That technology may become smaller and more inexpensive in the future, and we should always consider that as an option in the field. In terms of interventions, I think the first thing for all of our providers, and I preach this to the medics, is always be suspicious. In the elderly patient who is at acute altered mental status, they may be septic or have an infection. It may be a stroke, it could be something else, but always consider infection in those patients. If your index of suspicion is high and the patient rules in positive potential sepsis based on whichever screening tool you're using, start them on IV fluids in the field. Our current therapy for a patient is 30 milliliters of normal saline or Ringer's lactate as a fluid bolus at 30 per kilo. Medics in the field can start that bolus, and what is given in the field can be included in the calculation of the total bolus to be given. We encourage our medics to start IV fluids and start the bolus and to get the fluids in as fast as possible, even if not able to give the full bolus before they arrive at the hospital due to short transport times. Some of our providers are approved to give vasopressors, whether that's norepinephrine or in the case of what we use in central epinephrine is an epinephrine drip, but vasopressors can be used to improve or treat hypotension if the patient doesn't respond adequately to IV fluids. And then we ask our providers to ask for help, call for a pre-arrival sepsis alert so the staff at the hospital can ramp up in anticipation of expecting the patient. Next slide, please. What we've done with COTS, Central Health Trauma Systems, it's based in Columbus. It has a pre-hospital committee. The pre-hospital committee works along with the RPAB and with the hospitals and the pre-hospital providers. And we looked at sepsis about a year ago. We have had a sepsis white paper that's several years old, and we're in the process of finishing an updated version. We took the white paper, made it much shorter. Instead of 7 or 8 pages, it's now 2 pages. And we looked at developing a screening tool that we can distribute to our medics. The screening tool, to a large part, is based upon that article I just discussed. So what you're looking at is really what's going to go out as a wallet card or as a check sheet to be distributed to the medics. And we're going to look at or ask them to review the patient history. Do they have a suspected infection? Have they had a recent treatment or course of treatment with antibiotics? Any recent surgical procedure where they may have a complication of surgery? Have they recently been hospitalized, or do they have an indwelling catheter? Do they have a history of cancer, or do they reside at a long-term care facility or rehab facility? And so if they answer yes to one or more of those questions, we ask them to look at the clinical criteria, which again, kind of the abbreviated SIRS criteria: heart rate greater than 90, respiratory rate more than 20, or they have elevated or temperature lower than normal. If the patient has 2 of those 3 criteria met, then we ask for an end tidal CO2. And if the end tidal CO2 is less than or equal to 25, then we ask them to activate a sepsis alert. And then as part of their report, they will ask for the sepsis alert prior to arrival. We also ask that interventions be provided, that we manage the patient's airway if it's necessary. We give them adequate amount of oxygen to maintain adequate pulse oximetry, get at least 1, if not 2, large bore IVs started, and initiate a fluid bolus. Some facilities or some agencies have it called out as a 500 milliliter fluid bolus. Others, like mine, are asked to give, or at least start the 30 per kilo bolus and give as much as you can before you get to the hospital. We'll continue patient monitoring. We'll periodically evaluate the patient's breath sounds to make sure we don't overload the patient with fluids, and we'll promptly get them to the hospital emergency department for evaluation. Next slide. So how do we put this into practice? What I did is this is extracted from our current protocol for the agencies I work with. We have a protocol that's algorithm based and it's color coded. So EMT activities are in red or shadowed in red. Activities that can be done by anybody are shadowed in gray. And then advanced activities are yellow, and then paramedic activities are in green. So paramedic can do everything. Advanced can do up to the level of anything up to yellow and so on. So we have identified high-risk features for the providers to screen for. Start the patient on oxygen replacement therapy as necessary to maintain a PO2 of greater than 94%. If necessary, put the patient in the Trendelenburg position or at least elevate their feet. Screen for sepsis in terms of those SIRS criteria and end-tidal CO2. If there's no clinical evidence of CHF or pulmonary edema, we'll start at 30 per kilo normal saline IV bolus and check the patient frequently to determine whether or not they may have developed clinical symptoms of CHF. We'll request a sepsis alert by radio. We'll transport the patient emergently. And if the patient is hypotensive and doesn't adequately respond to fluids, we'll start them on an epinephrine drip at 2 to 10 micrograms per minute. We do that because we don't carry any other pressors in the trucks other than epinephrine. Epinephrine is good for multiple problems, and in the past we've carried dopamine and other drugs and never used them, so it really wasn't cost effective to keep them on the truck. You know, might we consider putting norepinephrine on the vehicles in the future for use for sepsis patients? I think that's something we can talk about as a community. Next slide. So where can we go from here? Well, I think we need to look at sepsis as a continuum. I think we need to get out of the silo mode so that what the medics do in the field should continue on arrival in the emergency department. I think one of the most important things we can do to influence pre-hospital provider behavior is to provide a sepsis follow-up report. We do that currently for myocardial infarctions, for patients who are victims of trauma, and for stroke patients. All of our facilities that I'm aware of in our catchment area provide this follow-up to the EMS providers. I think it's time to do the same for sepsis. The providers appreciate that. They use that as a tremendous learning opportunity, and it makes them feel good about what they do. And I think it's great community relations between the EMS providers and the hospitals. Is there an opportunity to talk about, or for us to obtain pre-hospital blood cultures and antibiotics? In a moment, I'll talk about that, an article that was recently published out of South Carolina. I think if we're going to do that, we need to look at what are our transfer times, and does this make it reasonable, or is it only going to delay patient transport to an appropriate emergency department? At some point, should we have a conversation about putting norepinephrine back on our trucks? Norepi is what we use at the hospitals for patients who are septic. We used to see it in the past as a drug. If we use this drug, it was the kiss of death, but now it's obvious that it does help patients. And then is there a role for pre-hospital lactates? If so, how do we get the equipment on the truck? Who pays for it? How do we maintain proficiency for the providers who are going to use it? Or could we continue to use the end-tidal CO2 as an acceptable surrogate to a serum lactate? Next slide, please. So this is an example of an EMS feedback form. We're looking to modify it for use in Central Ohio. It basically has to do with identifying the patient symptomatology, the transporting medics, so it goes back to the right crew, and then intervals of care. It has to do with door-to-room times, door-to-sepsis alert times, and so on. And these are intervals that we're already measuring as part of our hospital metrics. And then what was the patient's discharge status and their discharge diagnosis? Did it turn out they were not really septic, or maybe they were? We could also use this for patients who came in for other complaints, but who are later identified as being septic. That would be a great training opportunity for our providers. Next slide, please. This is the article I alluded to earlier about pre-hospital cultures and antibiotics. This was done in South Carolina. A pretty big study, 1,185 sepsis alert patients, and to qualify for sepsis alert, it was a suspected infection and 2 or more of the SIRS criteria. In the field, they obtained 1 set of blood cultures and drew a blood tube for serum lactate to be measured by the hospital on patient arrival. If there was feeling that the patient had pneumonia as their infectious process, they gave the patient a dose of IV ceftriaxone or Rocephin. For all other suspected sources of infection, the patient received piperacillin and tazobactam or Zosyn. If the patient was penicillin allergic, they got no antibiotics. They found that their blood culture contamination rate was 4.96%. They felt that was within community standard for blood cultures being drawn for providers with that level of training. I know it. I talked to my lab director the other day, and her goal is to get the contamination rate less than 1%. So I don't think she would go for this in the field. But to me, more importantly, antibiotics matched the positive blood cultures for 72% of the patients. I think I was impressed by that because we're talking about a single antibiotic for a potentially septic patient. Typically in the hospital, we give the patient 2, if not 3 different antibiotics, trying to cover all the bases. So I think a 72% match of antibiotic versus organism, I think, or sensitivity rate, I think that's very good. Next slide. So again, sepsis is a continuum of care. I think an opportunity for all of us is to partner with EMS on sepsis training for EMS providers. It has a much higher mortality rate, and honestly, our EMS providers are more likely to touch a septic patient than a patient with a STEMI or a stroke or significant trauma. We have an aging population. Many of our EMS agencies service 1 or more skilled nursing facilities, so they are much more likely to provide care for a septic patient than for a STEMI patient. Is there an opportunity for us to collaborate with EMS to purchase needed equipment so they have the resources they need in the field? And then can we collaborate on a common treatment plan? Helping EMS identify patients who are at risk, agreeing to a screening tool that can be used by EMS pre-hospital, work on a algorithm or treatment plan where EMS starts IVs fluids in the field based on at a pre-agreed upon rate to start volume resuscitation before hospital arrival. Make sure we have a process to initiate a sepsis alert prior to patient arrival, and make sure we mobilize our resources so that EMS sees that we take their concerns seriously. You know, we can always stand down and release staff members from the bedside if it turns out the potentially septic patient doesn't need that level of care. We need to make sure we have a prompt handoff on care and continuation of pre-hospital care. There's nothing more frustrating for EMS providers than to identify a critically ill patient. They arrive at the hospital and the hospital's not ready to receive them, or there's a delay in patient handoff. And then give timely, appropriate feedback to the crew. Was that patient truly septic? Did we hit those time intervals that are important for this patient? What was the patient outcome, and what could we do differently? I think it's also important that we give kudos to those crews that did a great job in evaluating the patient and bringing him to the hospital. Next slide, please. Potential pitfalls. You know, sepsis screening tool is too complex. We have to be aware that level of training varies between departments, and some of the things that we may consider reasonable screening tools to use at the hospital may just not be practical in the field. We also have to be sure that the screening tool does not exceed EMS provider's scope of practice. An easy example of that is expecting to do a serum lactate in the field if it's not within scope for them. Having a sepsis screening tool that has poor sensitivity or poor specificity, I think that's for everybody's sake. Patients who are potentially septic, we want to have a tool that is very likely to identify them via septic, and we don't want to have a screening tool that identifies too many patients as being potentially septic, but when they're really not. I think that would just result in sepsis fatigue, where we just don't take the EMS concerns seriously when they call in. Next slide, please. In summary, pre-hospital care, sepsis care, you know, it's not complicated, but it's not always easy. If you've seen one EMS system, you've seen one EMS system. We have to consider each system's idiosyncrasies, needs, and capabilities, and that needs to be linked with our hospitals that receive them. You know, there really is no perfect sepsis pre-hospital screening tool. At least we haven't identified one that we all agree with, and that the collaboration between EMS and the receiving hospital is absolutely essential. I think that's it. Any questions?
Well, thank you, Dr. Zeeb, for your presentation and your slides. From a true pre-hospital provider perspective, And certainly, not only from a pre-hospital provider perspective, but also from the perspective of the emergency department proper. At this time, we will invite participants to submit any questions that they may have through our chat box feature. Please take a moment and record your questions or your comments in the chat box, and we will be happy to read those questions aloud and present them to Dr. Zeeb. As all of the lines are currently on mute, we are only using the chat box feature to eliminate any extraneous noise. We heard a lot of information in this presentation, and some of the things, just in summary, that I think are of major interest to our statewide initiative is the use of the QSOFA in the field to give an indication of severity. And you talked about the protocol that was in place and that is now being refreshed. And one of the initial questions deals with barriers to therapeutic interventions. And wonder if you could comment, Dr. Zeeb, on what you believe the top 2 to 3 barriers are to therapeutic interventions either being initiated in the field, or if they're initiated in the field, continued in the emergency department.
I think the greatest barrier really has to do with IV access for 2 reasons. One, if we're talking about a basic crew, an EMT, and that's the only staff we have available on the truck, they may be able to identify the patient as being potentially septic, but they cannot start an IV. It's totally outside their scope. If you look at what we do in the emergency department, one of the biggest hangups we have with the potentially septic patient is IV access. Not most of our patients are not healthy 40-year-olds who have pipelines for veins that we could quickly get an IV in. So I think IV access, IV fluids is the greatest potential pitfall, other than identifying a consistent uniform screening tool.
Thank you. One question that has come in from one of our participants now is anyone using a checklist type document in the field to assure assessment and documentation?
That COTS document I showed will be distributed as a checklist. Many of our EMS providers now have electronic patient care reports, so there may be opportunities, depending on who their vendor is, to put a checklist in the report. The thing that typically works the best is a checklist that we can laminate. They can put on the side, on the wall of the internal compartment of the truck, or a tab or a pad of paper that's got the checklist on it. They can check it off as they evaluate the patient and drop it off with the staff in the emergency department.
Thank you. Our next question is, if a patient is a CO2 retainer, how does this impact the predictive value?
That could be a problem. It's one of those things, I think, where even if they are a CO2 retainer and they're blowing enough CO2 that it's less than 25, then yes, it's be considered a positive test. I'm not aware of any studies where you would take their known baseline CO2 and then try to determine how many points below that it needs to be positive. So I think that is a potential pitfall of using end-tidal CO2 in the field. If somebody is a retainer, they may not get down to that threshold of 25, in which case then you may just have to treat them based on your clinical suspicion. That's a good question. Thank you. That's a mind tease I'll have to think about for the next 24 hours.
Well, thank you. Our next question is, what handoff measures would be most effective on the part of the emergency department?
Well, I think one is to ramp up on request of the patients or of the provider. So if they ask for a sepsis alert, then have the appropriate staffing available and at the bedside when the patient arrives. I think the other thing, and this is not only related to sepsis, but give the pre-hospital providers a chance to give their report. So, give them 20, 30 seconds to tell you what's going on with the patient, pay attention, and listen to what they have to say, and then ask appropriate questions. Providers will get frustrated if they work hard on a patient and they start to give report and nobody's listening. So I think those are things I would recommend.
Thank you very much. If there are any other questions, please feel free to type them in the chat box. In the meantime, just a couple of announcements, and that would be that, as a reminder, our next call will be held on Wednesday, March 15th at 11:30 a.m., where we will continue our focus on another aspect of the sepsis continuum of care. So please mark your calendars for that, and as always, we will be sending out electronic reminders ahead of time. Also to remind you that following this program, as always, we will post the recorded version of today's program along with the slide set to our website, which can be found at ohiohospitals.org/sepsis and clicking on the education link. So those are available to you as well. Lastly, we will be creating a toolkit of continuum of care tools, if you will, and some of the ones that Dr. Zeeb mentioned today that may be in that toolkit would include things such as an EMS screening tool, a copy of the protocol, the articles that he referred to in his slide deck, and also the sepsis alert feedback form, so that you would have those available to you. Dr. Zeeb, another question has come in, and that is, do most EMS trucks have thermometers or a means to take a temp? Is that a given for all trucks?
I think most trucks have some capability. It may not be the best method. I know a number of trucks have the thermometers for tympanic membrane temperatures, which generally have, their validity has been questioned. Some will use a forehead strip. Some will do the old-fashioned oral temperature with an electronic probe. So most have that capability, but I can't say that all do.
Okay, and another question has come in. What would be your suggestion for areas that have a large volume of volunteer squads? We have found that not all squads have the same equipment available and a variety of skill sets.
Well, I think that suggests to me you have a great training opportunity and an ability to interface with EMS providers to the benefit of everybody. So can you develop a 30, 45-minute training program for them? Could you talk to them about their resource needs, and if they have a need for some equipment pertinent to sepsis treatment, is there a way to help them purchase that equipment and train to it? So I think that would serve as a great opportunity if you reach out to your providers, and I think it would really result in positive return to your institution.
Very good. And the last question that has come in is just for clarification. The caller is asking us to clarify the mnemonic COTS, what it stands for. Central
Ohio Trauma System.
Okay.
Originally started as the trauma data manager for Central Ohio, and over the past 15 or more years has also been involved with pre-hospital care.
Very good. Well, we are at 12:18. I would like to thank Dr. Zeeb for his time, his willingness to share his knowledge and expertise in this particular area with us. I also would like to thank all of you for being on the call today. One last reminder, if you are claiming continuing education, please be sure to fax back in the sign-in sheet and a completed evaluation form, and we will process that accordingly. Again, Dr. Zeeb, thank you so much. And this concludes our February meeting of the Statewide Sepsis Initiative. Have a good day.
Thank you.